Surgical procedures are performed in many diverse settings. Regardless of the surgical setting or the complexity of the procedure, the patient should be monitored postoperatively for their physiological and psychological condition in a controlled environment before transferring to the care of the ward nurse. Most patients remain in a post-anaesthetic care unit for a minimum of 1 hour. Once assessed as stable, the patient is handed over from the post-anaesthetic care nurse to the ward nurse. Patient handovers are an inherent part of patient care. Health professionals use handovers to report patients' medical conditions, adverse events and interventions, as well as completed investigations and treatment. Problem with information transfer may lead to uncertainties about patient care and potential patient harm. It can be suggested that standardised postoperative handover protocols and tools improve the handover process, facilitating patient recovery, such as administration of postoperative medications, such as antibiotics, as well as the prevention or monitoring of potential adverse events. The primary purpose of handover is to relay accurate information, enabling continuity of patient care. It is therefore vital that the post-anaesthetic care nurse hands over to the ward nurse the following information, verbally as well as charted: patient details, details of the surgery and anaesthetic administered, a baseline for physiological and psychological assessment, medication administration, particularly analgesias, post-operative orders, referrals and any specific information to the patient, IV fluids, details of intraoperative urinary catheterization and output, or surgical drains. It is also vital that the ward nurse cites the patient and surgical site in order to raise any specific questions in regard to patient care. As a result, a requirement of the registered nurse is to be able to give a comprehensive, detail-specific handover. One study suggests that 80% of serious medical errors are due to poor communication when patients are transferred between health providers. Another study discusses that the use of handover tools assist with gaps that may appear in handover practice, enabling effective communication and minimising adverse patient risks as the patient is transferred from the surgical environment to the ward nurse for further recovery and ultimately discharge. However, it may be suggested that other professionals, such as an anaesthetist, rapidly recite information, leaving nursing staff feeling intimidated and rushed, and therefore resulting in a reduced ability to pass on potentially critical information to the caring unit nurse. Therefore, it can be expected that ineffective communication disrupts patient transfer of information and adversely affects patient safety. As a result, it is therefore important that the nurse advocates for implementation of appropriate handover tools, such as an ISBAR format, at an organisational level to ensure that patient-centred care occurs. Furthermore, the nurse feels supported with the appropriate skills to ensure that they are able to facilitate a complete handover of the post-operative patient in a time-driven environment. As further illustrated by Milby, safety checks reduce complications, mortality, and improve information transfer between a multi-care team with a standardised practice, therefore increasing patient safety.